everyone, this is Sam.
And this is Karine, and we are Two Onc Docs.
We're teaming up with GU Oncology now to cover all things GU Oncology from ESMO 2024. So I'm here with our GU expert, Dr. Karine Tawagi, who's assistant professor at University of Illinois, Chicago, and my podcast co-host. And she's attended ESMO, and so we're going to talk about some of the key highlights in the way of GU Oncology abstracts.
Yes, there is so much that we could cover in the realm of GU oncology that was presented at ESMO this past weekend, but we're going to highlight a few of the interesting abstracts and do a deeper dive on one of the STAMPEDE arms, SUNNIFORECAST, as well as SUNRISE-4.
Agreed. And let's be real, we cannot talk about ESMO 2024 GU sections without first hitting on the Niagara trial, which was presented at the Presidential Symposium Sunday, September 15th by our friend and your colleague, Dr. Tom Powles. And so this study was reporting on the addition of durvalumab to gemcitabine plus cisplatin as neoadjuvant chemotherapy, followed by adjuvant durvalumab. So Karine, will you tell us about these exciting results?
Yes, it was extremely exciting to be in the room when Dr. Powles was presenting this data. So as you mentioned, it's perioperative gemcitabine cisplatin, and then you add durvalumab, and then after cystectomy, patients also received durvalumab. It met its event-free survival and overall survival endpoints, and there was a 25% reduction in death, so the hazard ratio was 0.75 with a significant p-value, and then there was a pathologic complete response of 37%. For patients that added durvalumab over just the traditional GemCis. And so this is exciting because it's improving, some of the path CR rates that we've seen with just platinum-based chemotherapy alone. I think there's still a lot of questions in this space in terms of adding ctDNA to perhaps guide who needs adjuvant therapy. There's another trial called the Modern trial, which is enrolling right now, which is kind of a risk-adapted ctDNA response in terms of what to give adjuvantly. But definitely it adds data to the perioperative muscle-invasive bladder cancer space. But I think in the coming years, we're also going to see a lot in terms of EV pembro in the perioperative space. So likely to continue to change. But for now, when we're in clinic, this is certainly an option that we can consider. And hopefully we'll be getting insurance approval for this regimen as well.
Yeah, this is great. Practice changing. It sounds like there's more stuff to follow, which is always exciting. And so next, will you tell us about the STAMPEDE trial? And I know there's multiple arms of this trial. So the one that we're going to be referencing is the one about adding metformin to ADT in metastatic castrate-sensitive prostate cancer.
Yes. So Dr. Silke Gilson presented data on adding metformin to ADT or androgen deprivation therapy for patients with metastatic castrate-sensitive prostate cancer. And these were non-diabetic patients, and they were randomized either to standard of care versus the addition of metformin. It was 850 milligrams once a day metformin, and then if tolerated, increased to twice a day. And patients were enrolled from 2016 to 2023. So in that standard of care arm, 82% of patients also received docetaxel chemotherapy in addition to ADT. But of note, only 3% received an androgen receptor pathway inhibitor. And really, the standard of care now in the MCSPC is that everybody gets ADT and an ARPI, so this should be 100% really. So again, when the study was done, that's where they were. And the OS and the PFS were both not significant for the addition of metformin. However, some of the metabolic parameters, such as reduced weight gain, fasting glucose, LDL cholesterol, and HbA1c were significantly improved with metformin. And we know that ADT increases the metabolic risk. And in terms of side effects, there were a little bit more grade 3 side effects, about 5% more in the metformin arm, and increased GI side effects. But in general, it seemed to be pretty well tolerated. And so this definitely needs to be further evaluated. As we're giving people these hormone therapies, we want to make sure that we're not increasing their metabolic risk, especially as patients with prostate cancer with our improved therapies are living longer.
Agreed. I think this is important because you're mitigating those potentially higher morbidity, higher mortality complications of these long-term great working treatments. So I think offsetting those metabolic parameters, I think that is significant to patients and long-term outcomes, as well as the, physicians taking care of these patients and writing for these drugs long-term. And so up next, Karine, can you tell us about an update from the SPLASH trial, which evaluates the efficacy of lutetium INT in PSMA-positive metastatic castrate-resistant prostate cancer following the progression on androgen receptor pathway inhibitors?
Yes. So we had 3 updates in terms of radioligand lutetium-based therapy, and one of them was SPLASH. And so patients were randomized to this lutetium INT. It's also known as PNT 2002. Again, they just make the names
They just
complicated.
roll off the tongue, so easy.
Yeah. And so the dose that they got was every 8 weeks, they dosed this for up to 4 cycles versus the control arm of an alternate ARPI, whether it was enzalutamide or abiraterone, after progression on a prior ARPI. So patients were allowed taxane chemotherapy in the castrate-sensitive setting if they received the chemo more than a year prior. So one critique, again, is that a lot of times if somebody progresses on an ARPI in the castrate-sensitive space, we switch them to chemo. So if they're eligible for chemo, they should certainly receive chemo. And so people have issue with this ARPI switch therapy. But there are some patients that do not want chemo at all costs. I have certainly a lot of patients in my clinic that do not want chemo. And so it's still relevant in that patient population. And they did allow crossover on the ARPI switch arm.
Great. And so the patient characteristics for this trial, correct me if I'm wrong, but I think the median age was around 70, 72. Most of the patients were Caucasian or white, but there was African-American populations, 11.6% in the lutetium INT arm, as well as 5.9% in the control arm. Minority of patients did have that prior taxane use, which you just alluded to. And so can you tell us the results of the trial?
Yes, so it did meet its primary endpoint, reducing the risk of radiographic progression or death by 29% versus the ARPI switch with a hazard ratio of 0.71 and a significant p-value. And the median rPFS was 9.5 months for this lutetium agent versus 6 months for the ARPI switch. The overall survival data is still immature, and it did meet some of its other secondary endpoints as well.
Great. And so can you quickly walk us through some of the adverse events?
Yes, so the adverse events for lutetium INT were dry mouth, nausea, arthralgias, back pain, constipation. That's usually what I counsel my patients that are going to get lutetium. It's interesting because this was presented at the same time as the PSMA-4 study, which also is lutetium 617, and there's a little bit more uptake in the salivary glands, so more dry mouth with lutetium 617. And then also of note in the 617 trial, they got a higher cumulative dose. So again, you can't compare across trials, but we're seeing a lot more evidence for lutetium-based therapy in the mCRPC pre-chemo state. And so for patients that do not want to get chemo or cannot get chemo, this is adding evidence to give lutetium, in this setting, so in the pre-chemo setting. There's still a lot of questions in terms of the optimal dosing and timing of lutetium. Ideally, we could tailor therapy to growth rates as well as individualized dosimetry to help improve the response and limit toxicity.
Great. And so now let's switch gears from prostate cancer to talk about non-clear cell RCC. And so let's talk about the SUNNIFORECAST trial, which again, the results were presented here at ESMO 2024. The trial is prospective. It's randomized. It was a phase 2 trial looking at Ipi-Nivo followed by maintenance Nivo versus standard of care in this population. So can you tell us about the demographics, and then we'll talk about results?
Yes. So there were about 300 patients enrolled. Majority were male, majority were poor risk. And in terms of the histology breakdown, 57% were papillary, 19% chromophobe, 5% translocation, 1% medullary. And so this is a very heterogeneous group of patients, but it's great to see trial and data for these more rare diseases for sure.
Agreed. And so what was the results of this trial?
So the study did meet its overall survival endpoint at 12 months in favor of the combination Ipi-Nivo immunotherapy arm. And that was 86.9% 12-month overall survival for Ipi-Nivo versus 76.8% in the standard of care arm, with a difference of 42.4 months versus 33.9 months. But one caveat is that the majority of patients on the standard of care arm received a TKI monotherapy, most frequently sunitinib. When you're thinking about non-clear cell in the metastatic setting, we generally, in the last few years, think about IO TKI therapy. So maybe at the time that this trial was done, especially because it was in Europe, there was not availability of these IO TKIs. But I think for most providers nowadays, metastatic, especially papillary, the most common non-clear cell, we're going for that IO TKI, Cabo-Nivo. We also have Len-Pem that's approved. And so that's one caveat. Again, when you look at this subgroups by histology, the numbers are smaller, but there did seem to be a higher response rate for the non-papillary subtypes. And then there were no new adverse events identified. I mean, we know Ipi-Nivo, it's used in clear cell RCC frequently, it's used in melanoma. So you know that you have to watch out for those IRAEs.
Right. And so was there anything else to note in the way of RCC?
Yes, we did hear a final analysis from the phase 3 LIGHTSPARK-005 study of belzutifan versus everolimus in patients with advanced clear cell RCC. And so this is what Dr. Brian Rinne presented in the post-IO TKI setting. We saw a PFS benefit as well as overall response benefit for belzutifan at 22.7% versus 3.5% with everolimus, but the OS was not significant. So it's still an agent that we're definitely considering in the post-IO and post-TKI setting, and it has been approved in that setting. We also had an update for TiNivo-2 by Dr. Tony Choueiri, and this is, again, looking at that question of IO rechallenge, immunotherapy rechallenge. And so these were patients with metastatic RCC in the second or third line setting and that had received prior immunotherapy. They did not have to have immunotherapy in the immediate prior line of therapy. And the arms were tivozanib 1.34 milligrams once a day versus tivozanib 0.89 with nivolumab. And the PFS was 7.4 months in the TiVo group versus 5.7 months in the TiVo-Nivo group. So it did not meet its endpoint. So basically, it just adds more data to we're not going to rechallenge with IO. But there definitely still is a role for tivozanib, in the second or third line setting to be considered, perhaps with kind of a narrower therapeutic index and less toxicity.
Good. And so lastly, let's talk about the SUNRISE-4 trial, which compared TAR-200 plus citalumab versus citalumab alone in neoadjuvant setting for patients with muscle-invasive bladder cancer. And so this population wasn't just muscle-invasive bladder cancer, but as patients who were either ineligible or did not wish to have neoadjuvant cisplatin-based chemotherapy. The trial included about 196 patients. Their histologies were confirmed as stage CT2 to T4 N0M0. And predominantly this was urothelial carcinomas. And all these patients were scheduled for radical cystectomy. So can you tell us about this TAR-200 device, what it is, how it works, and about the trial?
Yeah. I'm not sure if you had ever heard about it before, but
no,
here we are.
You guys allude to this pretzel device a few times when we talk to your amigos, and I'm here to listen.
Okay, so this is kind of a big deal in the bladder cancer world. So we have TAR-200, known as the pretzel device. And we've seen it in non-muscle invasive bladder cancer in quite a few trials in the last few years. So it's an intravesical releasing system. Basically, you insert it into the bladder. It's shaped like a pretzel. That's why it's called the pretzel device. And it has a sustained local delivery of chemotherapy into the bladder. And so in this case, it's gemcitabine chemotherapy. Again, it's placed through an indwelling catheter. It's a 2 to 3 minute office procedure. And the patients in this trial, about a third were ineligible for neoadjuvant chemotherapy. And then the remaining 2/3 were refusing neoadjuvant. So that seems kind of high. Of note also, almost a quarter of patients in both cohorts had variant histologies.
Very cool. And so what was the results of this trial?
So the study met its primary endpoint of pathologic complete response and had pathologic CR and POR rates of 42% and 60% respectively. Interestingly, the path CR for patients with an incomplete TURBT was 56% higher than in patients with a complete TURBT. And we saw that the results for the combination of TAR-200 with citrilimide had higher pathologic complete response rates than citrilimab monotherapy.
Pretty cool. And I'm assuming because you're delivering the therapy locally to the bladder without systemically like chemotherapy, I would guess there'd be less adverse events. But can you tell me about the adverse events with this novel combination?
Yes. So because it's placed in the bladder, the side effects are generally urinary. So they're low grade, but most commonly dysuria, polyuria, urgency, and hematuria. There was one death on the citrilimab monotherapy arm reported as hyperglycemic hyperosmolar non-ketotic syndrome. So I guess I just wanted to mention that because, even though immunotherapy is generally regarded as benign in terms of toxicity, and we're talking about all these trials that have, adjuvant immunotherapy and perioperative immunotherapy or doublet immunotherapy, there still are really serious immune-related adverse events, and it's really important to still be cognizant of that and to educate patients and to really think about the risk-benefit, because even though we're adding a lot more therapies in a lot of different settings, perhaps we're over-treating a lot of patients as well.
What cost?
Yeah. So at what cost? So we need to really pay attention to those really serious immune-related adverse events, I think, as we're continuing to do these trials.
Agreed. And so do you have any last comments on this trial?
Yes, I also just wanted to mention that there was also an update from Sunrise-1, which was in the high-risk BCG refractory non-muscle invasive bladder cancer. And that had CR rates of 84% with TAR-200 monotherapy. And the results were more beneficial in that TAR-200 monotherapy group than with the addition of citrullimab. So it will be important to continue to have biomarkers to identify which patients can have durable responses, to perhaps select patients for bladder preservation and avoid radical cystectomy altogether. So there's a lot of trials looking at this bladder sparing approach, especially for muscle invasive bladder cancer.
I was going to say, do you have any other bladder trials that you want to mention?
Yes, just very briefly, we had an update from Ambassador. So we know in muscle invasive bladder cancer, we have nivolumab based on Checkmate 274, but we also have adjuvant pembrolizumab with Ambassador, and it continued to show disease-free survival benefit at 45 months. And we also had an update there's a lot of excitement about HER2 in bladder cancer. So very briefly, we had an update on disitamab vedotin, which is an antibody drug conjugate to HER2 in HER2 positive treatment naive metastatic bladder cancer. And the overall response rate was 75%. So it was super high, and with a CR rate of 35% in the HER2 positive population. So there is a phase 3 trial ongoing in this space. And really, there was a lot of exciting GU data. I'm excited to hear more about some of the other updates in other tumor sites, but certainly as a GU oncologist, I was really excited to see all of this data. I think overall, Niagara is something that is relevant in the clinic as of today. I think ctDNA, and we didn't really talk about it too much, but there were quite a few trials talking about the use of ctDNA in the perioperative space for bladder cancer, and continuing to be a lot of exciting work to identify better biomarkers to target therapies.
I agree. I think circulating tumor DNA is the hottest topic in oncology. At first, a decade or so ago, it was immunotherapy, and circulating tumor DNA it's there. It's prime time in almost all solid tumors. And so I'm excited to hear more from GU, and I know we're using it in sarcoma as well as GI cancers. So this is awesome. And I'm also excited to hear HER2 continues to go up the ranks in all solid tumors. So kudos to all of our breast cancer colleagues who kind of paved the way, and everyone else in the solid tumors picking it up when it's driving. It works really well. So Karine, thank you so much for covering all these great GU abstracts and going to ESMO 2024. And so you and I will continue to do our thing on Two Onc Docs. We have our weekly podcasts that release on Mondays, and we cover mostly board reviews, but sometimes we do cool stuff like this. We cover the exciting up-to-date stuff. So have a great week, guys.